Welcome to the Rehab Link Secrets to Success podcast. I'm Lisa Chase, your host. And this morning, I'd love to welcome Dr. Carl Steele to our show. Welcome, Carl.
Hey, Lisa.
So Carl and I was thinking, how long have you and I known each other? And it has, been quite a long time. I think I probably met you back in maybe 1997 when I started taking the Michigan State courses, and I took Muscle Energy, and you were chairing the course. And I have to say that for the first time, I understood the pelvis. Carl is an excellent teacher, and he can take the most kind of complicated scenarios of mechanics and make it very simple. And over the years, we've known each other a long time, and Carl really has become one of my mentors. He's my go-to. He has a great, interesting background that I'd love to have him share, but he started off as a physical therapist, ended up as a family practice DO, and had a practice in Port Clinton, Ohio, where he combined medicine and manual manipulation, and has helped a lot of people. And honestly, anytime I had a complicated case, the go-to guy is Carl. He just has a way of thinking and putting so many pieces together and figuring out what the problem is. So with that, let's just jump in, Carl. Let's tell the listeners a little bit about your journey and your history of how you came to be where you are today.
Well, it's a long story because I'm old, so so that's the I guess the part about it, and really I had kind of a destined choice to be where I am, I think, and the weird part about it is it all started with my mom's bridge club, which sounds really weird because I had no idea what I was going to do with my life. And in that bridge club, one of the other participants happened to be Rick Bowling's mom. And if anybody who knows anything about orthopedic physical therapy, they know Rick Bowling. And Rick Bowling grew up in my hometown, and he was the first I guess contact I had with physical therapy at all. And so Rick kind of became my role model, and unknown to me, Rick was one of the premier guys in orthopedics. And I tried to kind of emulate what he did. And after I got into PT school, I went and did my externship with him and learned my first orthopedic manual technique back in 1976, because that's when I graduated. And I learned it studying with Rick, and actually did my very first lecture in a CME course with Rick Bowling, Dick Earhart, and Sandy Burkhart. And it was on complications of cervical manipulation. And we did that someplace in West Virginia, where those guys were doing a course while I was rotating with Rick. And so that was my introduction, both to really manual medicine and also, teaching manual medicine. Although I'd already been an anatomy instructor at Ohio State. So,
right.
But, and then subsequent to that, I finished my PT education. Went straight into and got a master's degree in anatomy, which was a great setup for what I did later. And then I went to work at a place called Doctors Hospital, and that was a DO institution. And at that point, I'd never had any interaction with DOs at all. And while I was there, I got to teach a cadaver lab, and I met the residents and became friends with the residents. And then subsequently moved to Detroit. And then in Detroit, I was asked to go see a patient at another hospital. And I ran into a neurology resident there. And he had all the mannerisms of one of the residents that I knew from Columbus. And I said something to him, and he said, well, what's the guy's name? Turned out the two guys had lived together for 5 years and both had done manual medicine fellowships with Phil Greenman at Michigan State. And so the way I got attached to Michigan State was through that neurology resident. He invited me to take a course or to see a lecture at Botsford Hospital. And the lecturer was Phil Greenman. I got introduced to Phil Greenman. And after the lecture, I asked him if there's any way that I could take, or I could get more exposure to the stuff he was teaching.
Yeah.
And he said, yeah, we just started a manual medicine series at Michigan State, but it's for physicians only. And I suppose if you came with a physician that you worked with, you could audit the course. And I think that he never expected to see or hear from me again. And I went back to the hospital where I worked, and I knew one physician. And I asked him about it, and he looked at me and said, where did you hear about this? And I said, well, at Botsford, I talked to a neurology resident. And he said, well, what's his name? It turned out that neurology resident was his favorite nephew. He picked up the phone and he called his nephew, and he came out and he said, we're going to Michigan State. And so I became the first physical therapist ever to go to any of the Michigan State courses, which at that time, that was 1980. They were initiated. The first muscle energy course ever was done there in 1974 after Fred Mitchell Sr. died. And so I got there in December of 1980, and they had been doing it for, I think, about four to 6 years. And that's the whole sum of muscle energy teaching anywhere. It just wasn't out there. And so I got exposed to it pretty early.
Yeah. Yeah. And then you went on to become a DO.
Correct.
Yeah.
What happened was when I started taking the courses, after I got to the first one, they allowed me to come back and take the next and the next. And I just signed up for everything I could get as fast as I could get it.
Yeah.
And then Fred Mitchell Jr. was teaching the muscle energy course at that time. And I was working for the Henry Ford system in Detroit. And we needed to have some CME. And I asked Fred if he would teach a course for the Henry Ford program. And he said, yeah, if you'll teach with me. So I started teaching the anatomy and biomechanics for Fred when we did those courses. And then subsequently, somebody didn't show or had a conflict. And Fred said, well, Carl can do it. And so I ended up going to Michigan State as a PT with a master's degree in anatomy to teach in their CME series, which created a lot of havoc because how could a PT, be involved in teaching at that level? But what I taught was anatomy and biomechanics. And so the people at Michigan State had no problem with me doing that. And then after I did that for a while, I got an invitation to go to Michigan State on a faculty development track and go to the DO school. So that's what I did. Then I did a DO internship, and then I did an allopathic family practice residency. And so ended up being a family practice physician with a heavy bias to musculoskeletal medicine.
Yeah, I know. Well, I know,
That's,
many years and a lot of vast experience for sure. So I know that, you know, you get amazing outcomes. I mean, as one of my mentors, I really have tried over the years to really pick up those little nuances. And for you, like the thing that I love is it's like you just keep it super simple. You know, it's like, let's not overcomplicate things. How do we just make this, you know, same or different? let's make it super simple. So let's talk about and share with the listeners kind of, you know, your tips for getting great outcomes.
well, I mean, the first thing is to be clinically honest with yourself.
Mm-hmm.
And that is whatever you do, it's check and recheck.
Yeah.
And did you make a difference? Did what you applied change something? And how did it change it? And so that's the first thing. I see people treat and not recheck, and that's just like, how do you know? You
Yeah.
don't.
Yeah.
So I'm always, you know, testing my outcome. I have this continual N of one, and each technique I try is its own clinical trial. And I guess the second point that goes with that is failure is really a learning opportunity. And so the second point I would say to people is that the only difference really between me at my experience level now and me before is I fail more often now. And when I try something, introduce some sort of intervention with the patient, and I recheck it, if I don't get what I want, then I modify that. And I joke with my patients, I go, oh, that was plan A and plan B and plan C. And so that trial and error, and then knowing what the options are, how to modify that so that plan B is treating the same problem, but doing it from a different angle or a different set of biomechanics or a different combination of biomechanics, makes all the difference in the world. And when you start out, you only have plan A because you don't know enough as far as all the different nuances and principles of how you can approach these problems. And so in the biomechanical model, it's almost an infinite variability on how you approach problems. You can come up with all kinds of combinations. And so I think I figured it out one time. It was 10 to the 68th or 65th power of options. And so that's a lot of choice.
It is a lot of choice.
Yeah. And so those are the big two, to be honest. And if you don't get the response that you want, that failure is a learning experience to try something different. Mm-hmm. And keep track of that. And so, you know, that's always, I think, the most important thing. And the other thing is that, you know, when I treat a patient, my intent is always to help them and change things for the positive. And I think that's probably the other big piece of the puzzle, the number three. I don't start out thinking, oh, I'm probably not going to be able to change this. That isn't my come from. Right. My come from is, we're going to make this different. And then you start and you try to produce a positive outcome. And you know, there's a lot of nuances to that. Is where do you start? What do you do? What do you do second? You know, the sequence of how you do things is critical. And a lot of people don't appreciate that.
Well, and I always, remember you saying, like, when you do your introduction in muscle energy, is you only need to make a small change, right? To input into the system that sometimes there's so much, neurological, overload to the nervous system that sometimes just making a small change will get them underneath that threshold of pain, right? So it's finding that right lock and key, but just a small change can make a huge difference. I think sometimes we may over treat by trying to do too many things. Like you said, okay, evaluate, treat, reevaluate. And then sometimes, you just go, okay, that's enough. Now let the body kind of reset. And, I kind of really keep that in mind as well.
Yeah, and the important word that you mentioned is you're treating a system.
Yeah.
And whether it's the musculoskeletal system or the organism as a whole, which is a whole complicated interaction of other systems, is that whether that they're symptomatic or not is a function of how much adaptability they have left. And so and that's also the big problem with research studies is if you're basing your findings as to whether or not you were successful or not based on symptoms, what you'll find is that a patient has a symptom and you have 16,000 different practitioners with 16 different treatments, and all of them claiming to cure that particular symptom.
Mm-hmm.
And what I would say is what the way we should really look at it is that they are reducing stress in that system to the degree that the patient is now able to adapt and function at a symptom-free level with what they have left.
Mm-hmm.
And so it's a curse, because most of the time there's more than one problem in a system.
Yeah.
And the real blessing in that same deal is that you don't have to fix everything in the system to make it asymptomatic. And
Yep.
so you just need to bring them back to a point where they have enough remaining adaptability to be asymptomatic.
Yeah.
And as you're 100% correct. You don't have to fix everything, but you have to fix those critical things that bring you below the threshold of symptoms.
Yes, that is so true.
And so, yeah, that's a huge piece.
I think, the other thing that I really learned from you was how or the expectation of or response to treatment, positive or negative, will give you the information that you need to know, okay, especially like whether it be as a primary care, family practice, obviously even more critical, but as a physical therapist, if somebody comes in, and you and I have talked about many of these cases where somebody came in, and they had your typical, tennis elbow, and I, treat the way I normally would treat, but the expectation of how I thought, or how I know it should have responded, it did not. It actually got worse, was a red flag. And you have always taught me to listen to that and to go, okay, stop, because this is not the normal response that I should be getting. And I've caught various different things. Like in that particular case, that was a tumor that was in the elbow. And it was actually just not responding the way that it typically should respond. So I'm sure you can kind of talk to that point. And I know you've had many of those, scenarios.
Yeah. Yeah. The musculoskeletal system is just another window into the body. You can palpate, you can auscultate, you can image things. There's lots of ways to approach the system. And so when you have somebody that comes with what you think is a musculoskeletal complaint because it's got pain or spasm or dysfunction somehow, and it doesn't respond to mechanical treatment in the way that your clinical experience, if you have good clinical experience and you're honest with yourself, then you have that red flag that this is not behaving as if it's a musculoskeletal problem. So what is the viscerosomatic reflex that can cause referred pain to that area or structure? Or what is the viscerosomatic origin of whatever musculoskeletal manifestation you're seeing? And it is a huge benefit to me as a clinician, because if it doesn't fix, I know it's not musculoskeletal.
Yeah.
Or if it doesn't change, at least
Right.
respond to treatment, because viscerosomatic stuff does not respond well to musculoskeletal treatment.
Yeah, exactly. Yeah. I mean, and that has saved me time and time again. And sometimes it might not be that it's outside of the musculoskeletal system. At least for me, it may be like, okay, you need to get further diagnostics because maybe there's an extruded disc, or there's something that's not going to maybe respond to the mechanical, types of treatments. And so what other things might, as a physical therapist, we may need to pull in, a medical practitioner or diagnostics to make sure, hey, we're on the right track, because you do expect that certain things, should respond in a certain way as well.
Yeah, and that brings up the other point is that, with physical therapy having open referral, that exposes you to all these people that may or may not have adequate medical evaluation. And so the other thing too is that just because they come with a referral from a physician doesn't necessarily mean they've had adequate workup.
Yes.
They may just come in and if you don't do an adequate review of systems, or if the patient isn't completely honest, it's easy to miss stuff. And the other thing that's critical and also speaks to my favorite question, over time, are you better, the same, or worse? The tincture of time is a huge variable. And so you can have a clinician who examines a patient who at time close to zero has a symptom but no physical findings.
Mm-hmm.
And they show up on your doorstep a month or 3 months later with the same symptoms, and a good physical exam is going to have completely different findings, because there's a process that's involved and it changes over time. And so just because somebody was evaluated a month ago or 2 months ago or at some period, or it feels just like it did before, that doesn't excuse you from doing a good history review of systems and a good overall physical exam, including a neuro exam. And where physicians are responsible to make a diagnosis of inclusion, your responsibility as a PT is to make a diagnosis of exclusion.
Yeah.
And so I don't see any difference in the workload.
Mm-hmm.
I think it takes the same amount of exam to do it. Because most of the time when I do imaging, I'm pretty sure about what the diagnosis is going to be.
Right. Yeah. No, and you taught me that too, just asking the right questions, doing the review of systems, and a good clinical exam, and that quick neuro exam that you teach, in muscle energy. I mean, I use that with every single patient, upper, lower quarter, no matter what comes in the door. And I have caught all sorts of stuff because of doing that exam. So yeah, that's critical.
Yeah, and that exam is exactly the same exam I learned from a neurosurgeon in 1976 when I was working at my first job as a PT.
Oh.
And he showed me that exam, and I've used it ever since.
Yeah.
And so it's been invaluable.
Yeah.
So, yeah. Yeah, you cannot underestimate clinical experience. And the problem is that when you come out of school, you think you know a lot of stuff. But if you're clinically honest with yourself, when you really start to interface with patients, your outcomes aren't that hot.
Yeah.
And if your intent is to truly help people and be a good clinician, then it's going to take a lot of work to get there.
Yeah.
Because it's not, you can't read it in a book and step in and do it. It doesn't work like that.
Over 10,000 hours, isn't that what they say?
I would say,
But I think it's more.
That's the beginning.
That is the beginning.
That's 20, 80 hours for a full-time job, and that would get you to 10,000 hours in like 5 years. 5 years, I was coming to the realization, and I really didn't know anything.
Yeah, right. Isn't that
At
so
all.
true?
And so I would say it's a lot more than 10,000 hours.
It really is. Yeah. And nothing takes the place of clinical experience. It just really doesn't. And, I mean, I've seen that, over the years. I know you have, and, so yeah. So
Well,
I know that so you teach at Michigan State, and you obviously have taught, and, you've gone to Italy, and you've gone to Asia and all sorts of different places, and you've taught. What would you say that your audience most appreciates about kind of you and some of your little nuances that you teach, that have kind of given those students those aha moments?
That's hard. I think probably for everybody, it's going to be a little bit different. I don't know what they appreciate the most about me. I guess you would have to ask people that take the courses.
I can tell you.
Well, then, two things. I think from my standpoint, I try to be honest in my approach. I don't teach things that I don't do or things that I can't make work.
Yes.
And I think that's a huge piece, because a lot of times there are techniques that get taught by people who don't do them, and aren't aren't in the trenches doing the work.
Yeah.
So I think that's the one thing. I think when clinicians teach, it's different than when academics teach.
Yeah.
And so I think that's probably what people appreciate the most. And then the other thing too is that when we are involved in the course, invariably we're going to find participants that have problems. And so I picked this up from Paul Kimberly. I mean, his commitment when we taught is if you bring a problem to the course, we'll fix it before you go home, or we'll try to fix it. And so that was one of the things that we had always done with course participants, that during the process of the course, we tried to make sure that we took care of problems that people came with. And so it gives you a clinical experience personally during the course that something's changed, hopefully for the better. And then over the years, what I've learned is that I've restructured the courses to be essentially in the treatment sequence that we use in the clinic.
Yeah.
Because if you don't do that, you get in trouble really fast.
Yeah.
Where you're trying to interface with the population that you have, which is the course participants you're teaching, and they're all going to bring some level of dysfunction into the room.
Yeah.
And so you can either work through that successfully, or if you do it out of sequence, you're going to create really a clinical nightmare where you've got the, the cart in front of the horse.
Right.
And so I think that's the other thing is that, when we teach the course, a lot of times people will say, well, can you fix this for me? And I'll say, let's see if your partner can fix it for you. And if they don't, I will.
Yeah.
And so most of the time now, their partners clean up most of the stuff that they bring in. And so that's really my biggest goal is that they can personally experience a change. And so it brings kind of a validation and also demonstrates that this stuff can be effective when you use it on patients.
Yeah.
So.
Yeah. And I mean, and like, so an example of that for the listeners who, if you're not doing this approach. So if somebody comes in with neck pain and they've got high tone in their neck, what we typically do is we go down to the thoracic spine and we try to find where the facilitator of those long restrictors are to clean those up first before addressing the neck. So those are the kinds of things that Carl's talking about, that and the muscle energy courses, that's how we lay it out. You start in a certain region and you work your way just like you would do in the clinic, because if you try to go after the neck before you go after the T-spine and the rib cage, well, especially that first and second rib, yeah, good luck. Yeah.
And the goal of manual medicine is to restore maximal pain-free motion and postural balance. And then I always add with normal motor control.
Yeah.
And so, patients who come in with neck problems and they have a forward head posture and they're tail tucked and they're flexed at the lumbosacral junction and the TL junction, there's no way their neck is going to respond to anything you do if you can't get them back in postural balance. So that's job one.
Yeah.
And so that's where insurance companies and work comp are ridiculous, because if they get a neck diagnosis and you're limited to only treating the neck, you're destined for failure.
Yep.
Period.
Absolutely. Well, I know that I've certainly appreciated your friendship and your insight over the years. I always love teaching with you and the faculty at Michigan State, because it keeps me honest and it keeps me on my toes. And, I learn something every single time I teach. Just hearing something, a little bit different twist on it, or hearing it when I maybe didn't hear it, several years prior. So I appreciate you and all that you bring and how you've really impacted my clinical practice and my ability to be, a better clinician. So thank you.
Thanks. Yeah. And I think what's happened at Michigan State is really unique to have a collaboration where, I started, I was the youngest guy. I was literally in my late 20s when I started teaching. And I taught with Manel and Bordillon and Greenman and Kimberly and Ed Stiles and Fred Mitchell Jr. And had contact with guys that were, just legends.
Yeah.
And the founders really of a lot of this stuff. And then to build a core curriculum and a faculty that's been together to the degree that we have is amazing. I've been there, I think, I started teaching in 82. I started chairing in 92. And so that's, 40 plus years.
Yeah.
And we've had with for most of the years, consistent family of faculty
Yeah.
that's contributed. I mean, we lost Mark. That's tragic, but he contributed so much.
Yeah, you sure did.
And Ed and Sam, and now with the rest of the guys, hopefully we keep the band together.
That's right.
And I learn every time I teach too.
Yeah.
Something, somebody teaches me something, or somebody points out something that you haven't thought of. So the collaborative core of people that are doing the work and bringing, more stuff to the table is super helpful. And so hopefully it'll continue to evolve. I know I always say the courses that we teach now are not the same courses that we taught 10 years ago, because they've evolved.
Yeah.
And hopefully they will continue to evolve.
Right.
So
Absolutely. Well, I am going to put a discount code in the show notes. So if anybody would like to come and take a course at Michigan State, we'll definitely offer that, because I would tell you, absolutely changed my clinical practice, going to Michigan State and learning this model. It makes a huge huge difference in your outcomes. So I appreciate you coming on the show today. Is there, if somebody wanted to find you or connect with you, is there a way for them to do that?
yeah, actually I'm, I've been in the same location for, 31 years, or 32 years in the practice. So, I'm in Port Clinton, Ohio. They can call the office. They can, if they want, they can send me an email. It's cwsteele@roadrunner.com.
Awesome.
And, or come to Michigan State, and then we'll carry on from there.
Absolutely. Well, wonderful. Well, thanks so much for sharing your insight. And until next time, keep getting great outcomes.
See you, Elise. Thank you. Bye-bye.